are not yet live.
Okay.
We are going live. We are just connecting. In a moment, we'll connect. I'll tell you when we are.
Yeah. Munjit, later on, could you ask Claudia to send me the permission given by the Australian FDA for the OPL?
Yeah. What do you want?
The permission, like the food FDA permission that is there to use that implant, because I spoke with a couple of people here. They said that we'll have to give that the documents, supporting documents to allow that implant to be used in India.
Sure. Yeah, easy. I can. She's hearing you, so she'll do that. Yeah.
Okay, we are live.
Should I start, Shyam?
Yes.
Good afternoon and welcome to the first hip arthroplasty webinar during this lockdown period. Today we have a great faculty from across the world. We have Mr. Nikhil Shah, a consultant at Wrightington, who is going to talk on cemented hips. We also have Dr. Munjed Al Muderis from Sydney, Australia, who is going to talk and show us videos on anterior approach to the hip, and will talk on uncemented ceramic on ceramic hips. And later on, I, Dr. Abhijit Joshi, will talk on reverse hybrid. Over to you, Shyam and Nikhil. For any questions, please WhatsApp your questions to Ashok Sham or me on 9820
So can I start, Abhijit?
Yes, good. You're on.
Okay, so the remit of my talk today is to show you that cemented total hip replacement is a viable option in modern orthopedics. In fact, in my personal view, it is a better option. It has a lot of evidence associated with it. So the way I'll run this talk is I'll show you just an introduction of a cemented total hip replacement and a brief word on the history. Then I'll show you some steps, which are intraoperative photographs of the technique of a cemented total hip, the way we do it at Wrightington Hospital. After that, we'll go to a short video, which will show how the operation is done. And then we have a few cases at the end for discussion. If we get time, then I can show some of the evidence. So just as a way of introduction, I don't know how many from the audience who have joined the webinar have ever seen a long-term follow-up of any form of hip replacement at 50 years. I doubt that any one of you have seen that. So this is the X-ray of a 50-year follow-up of a cemented low frictional torque arthroplasty done by John Charnley with a 22 millimeter metal head on a monoblock first generation tapered polished stem, which was a Charnley arthroplasty, and a cemented cup. And this really summarizes the legacy that Charnley has left us. So let's go to some history. I'm sure that all of you know the concept of low frictional torque arthroplasty using a small 22.225 millimeter femoral head, which creates a low frictional torque and allows the use of a thicker polyethylene. It optimizes the head-neck ratio and gives good long-term results. So these are some of the other slides of the way Charnley developed his hip replacement. Presently, what we are using is a C-stem, which is a triple tapered polished cemented stem with an acetabular component that is also made of polyethylene and is cemented. And we have good data coming up to 15 to 20 years now of the C-stem. So let's go to how we actually do the surgery. So this was a case that I was going to show, painful arthritis of the left hip. It's important that you concentrate on patient selection. The patient should have symptoms that correlate with clinical examination findings, causing sufficient pain, affecting function, and that should correlate with radiological evidence of good grade 4 end stage arthritis. Templating is very important. Even though it might not always accurately predict the size of the components, it does help draw your attention towards issues like leg length, like offset, and if you do templating on the lateral side, any femoral deformity or acetabular problems. We also tend to get x-rays of the spine if required to look at your spinopelvic alignment. So I do my total hip replacements using a standard posterior approach. And I was told that all of you will be familiar with a posterior approach. So we won't spend too much time discussing the surgical approach. This is my setup in the operating theater. We have laminar flow and all your typical striker hoods. The patient is prepped and draped. Make sure that the patient is positioned correctly so that you know exactly where the pelvis will be. So I like to expose the sciatic nerve and identify it. And in cases with heavy muscular people or high risk cases like DDH, I would release the gluteus maximus tendon insertion that helps to relax the sciatic nerve. Another useful pointer to relax the sciatic nerve is to keep the hip extended and the knee flexed. So going ahead, after taking down the short external rotators and the capsule, which I like to do in 2 separate layers, you mark the length. So I use a Charnley pin in the supraacetabular area of the bone and then mark the length using the links on the chain. And in the end, once you have done your trial reduction, you can check the length again. Then you dislocate your hip, the neck has been cut, and that's the exposure of the acetabulum. So this is the left hip that we are looking at. And this retractor is the anterior wall retractor, which is positioned anteriorly and superiorly. And this is the inferior retractor, which is positioned where you would normally find your transverse acetabular ligament or the TAL. The purpose of reaming for a cemented hip replacement is not really to expand the socket. And philosophically, this is where it probably differs from an uncemented socket. The purpose is only to take out the cartilage from the acetabulum and to try and save the bone. So we like to do a bone preserving operation. Reaming is minimal. It is only designed to take the cartilage out and to give you nice bleeding bone. And if there is good subchondral bone, then I would preserve the subchondral bone as well and make multiple drill holes for the cementation. So this is the step drill for making multiple drill holes so that you can get your cementation nicely. And you can see the punctate bleeding in the acetabulum. This is a cup holder, which is used for holding the cup. So the standard head size that I use is 28 millimeters. In smaller patients, I have no hesitation in using a 22 millimeter head. And rarely I would use a 32 millimeter head. So this is a marathon polyethylene cup. That is the standard that we use at the moment. This is the peroxide. Once you put the peroxide swab into the acetabulum, it gives you a nice dry surface. Pulse lavage is very important for modern contemporary 3rd generation cementation. Wash out all the debris, make sure that the drill holes are clear to take your cement and the surface should be dry. That's your cement being pressurized. And that's the pressurizer that we use. It's like a blue rubber diaphragm. You can actually use a dry thumb to squeeze the cement and directly put it into the individual holes before this goes on. Once you've pressurized it, that's the socket going in. You judge your inclination and your version using whatever usual landmarks you use. There are always multiple landmarks, including the transverse acetabular ligament. And once you have done the acetabulum, we go to the femur. Again, the key in the femur is to get an entry point that is adequately lateral. And then you clear the loose bone using broach. Try and preserve good cancellous bone behind so that you can get good cementation. To occlude the canal, you can use a synthetic plug like Sarah plug or BioStop or whatever is commercially available. In this case, and my preference is to use a bone block. So the instrument that you can see in the top right picture is a Wroblewski bone block harvester, which is like a hollow mill or a corer basically. You take the bone block out from the proximal femur and you compact it. Then you do the remaining steps, opening up the proximal part of the femur, with your reamers and then broaching gently. Once you've got your trial broach in and you've finalized your size based on your template, you do a trial reduction. In a trial reduction, you check for impingement, for instability, take the hip through a full range of movement, do the combined anteversion test, make sure that your length and your offset is restored. And that's the way I check for hip stability, check for lengths, check the shuck so that you know your tension is correct. And once you're happy with that, then you can go ahead and perform your cementation. So that's the bone block going in into the femur that will occlude the canal. And once you've washed it and dried it, you get a beautiful cancellous host surface to take the cement. That's the cement going in with a gun. This is standard setting CMW cement. For the acetabulum, I used a fast setting version of CMW. Then you pressurize your cement in, and that's your final stem going in. You can control the version of the stem based on your trial reduction. Once your stem is gone in, you can repeat your trial reduction. The final head size, in this case, I've used a metal head, and then a formal repair of the posterior approach with whatever technique that you are used to. That's the final X-ray, which shows the total hip replacement. Well-positioned stem, well-positioned socket, a good whiteout on both sides. And another example of a cemented total hip replacement. So what I'll try and do now is I'll dive out of this presentation. We'll come back to the data on survivorship if we get time. And I'll try and open the video. Which shows the similar steps. It works. Excellent. So we'll start again where the acetabulum has been exposed. That's your fat pad. The reaming has to be performed very gently. The idea is not to take away too much bone, but just to take the cartilage away. Even if there is some irregularity in the overall shape of the acetabulum, it does not matter. Osteophytes are coming out, and then the cup sizer. So I know what, I like to leave about 7 millimeters between the size of the reamer and the size of the cup that I take. So if I've reamed up to 50 millimeters, which is the top size of the reamer, then the cup would be a 43 by 28 cup. Those are the drill holes going with the step drill. And then peripherally, there is often very good sclerotic bone. And there is some cartilage as well. So that was a ring curette, which takes the cartilage out. Then you do your pulse lavage and dry the surface with peroxide. For the acetabulum, we use bowl mixing. Your cement goes in, and a combination of finger pressurization and pressurization with the help of the blue diaphragm. So for fast setting cement, it usually sets between 5 and 6 minutes. So I would pressurize till about 2.5 to 3 minutes, and then my cup would go in. If your patient is correctly positioned in the lateral position and that rod is perpendicular to the plane of the floor, then you get your inclination to about 45 degrees. And your version you judge according to your usual landmarks, especially the transverse acetabular ligament, wherever it is visible. So the excess cement is coming out while my assistant holds the cup in the position by putting that rod. And with the 2 fingers, you can fine tune the position, hold it steady until the cement has set. Clean everything out. And that's the local infiltration technique, which we use routinely for pain management. And especially if you're doing overnight stay hip replacements, or if you're trying to move towards day case hip replacements, the key really is good pain management. That's the femur now. The bone was quite sclerotic, so I'm using an osteotome just to define the proximal neck. And then that opens up your lateral entry point, the trochanteric reamer, just to create the space in the proximal femur. And then the taper pin reamer to just establish the canal. Try and stay as lateral as you can so that you go straight down the femur and the stem does not go into varus or valgus. These are the broaches for the standard C stem. So we use the classic C stem, which has a 9-10 taper. Some of my colleagues also use the AMT C stem, which has a 12-14 taper. I think, Abhijit, the classic C stem is not available in India, is it? It's mainly the AMT.
Yeah,
so that's the trial reduction. And you can see
is available.
Correct. So I'm taking it through a full range of movement, flexion, full adduction, complete extension, internal rotation, external rotation, check for impingement, then check your leg lengths, measuring the, and you know based on your templating how much lengthening you want to achieve, if at all. A few millimeters of lengthening is almost inevitable because when you get arthritis, you actually lose length. Now, in this case, I've used a synthetic occlusion device that was a biostop, pulse lavage to take out all the cancellous bone. So for the femoral side, for this particular case, I'm using Palakos gentamicin cement. And it comes with its own mixing gun. It's very important that you train your nurses to mix the cement correctly because cementation is all teamwork. It's not just down to the surgeon. It has to be mixed correctly according to the manufacturer's instruction. And there is a learning curve to doing a cemented hip, just like any other surgery, really. So the cement is going in, pressurization of the cement. You can see the fat coming out if you pressurize it nicely. So for Palakos, it takes between 10 and 11 minutes to set. It does depend upon how it is stored and ambient temperature. So I tend to pressurize it till about 4.5 minutes. The stem usually goes in between 4.5 to 6 minutes or under 5.5 minutes usually. You can see it's going in comfortably. That thumb, if you leave the thumb on the calcar and just use the rod pusher, you get your stem going perfectly in the center of the femur without any varus or valgus. Ceramic head that has gone onto the stem once the cement sets. Before the ceramic head goes in, I would normally do a trial reduction and then put the ceramic head in. So I think that's the end of the video. And we can move on to the cases now. So we'll start with the cases that you normally get in your practice, just some simple straightforward cases of different types of arthritis. Abhijit, is it still visible?
Yeah, it's visible. You're going fine. Everything good. Just full screen.
Okay.
Yeah, good.
And we're okay for timing?
No, you're doing good. Please continue.
Okay.
These are interesting cases.
So this is an example of a protrusio hip where the femoral head has gone medially. Now the key for protrusio to get a good result is to perform bone grafting of the floor of the acetabulum. Whether you use cemented sockets or uncemented sockets is up to individual preference. But in this case, you can see that with good bone grafting and a cemented socket, and even at 10 years, it looks like it was done just last week. So good data of cemented hips in protrusio, good long-term data. So this is a typical case. We get a lot of DDH in young adults and adolescents. So a large part of my practice is doing hip replacements in 17 and 18-year-olds with DDH, with SUFI, with sequelae of Perthes disease, infection. And these are often multiply operated patients. They have had 4 or 5 open surgeries. Sometimes they've had Elizarov hip reconstructions, leg lengthening. So these are really challenging operations. You need a lot of planning. And this is not a DDH lecture, so we'll not discuss about the hip center and everything. But you can see that my preference is to use a cemented socket using a structural bone graft to make up the deficit superiorly and posteriorly. These are small-sized cemented stems. These were designed in the about 20, 30 years ago for smaller sized bone. They're called Asian C stems, but you get small sized patients in all ethnicities. And you can see the follow-up at 10 years with the femoral head bone graft united nicely, and the hip replacements also looking quite nice. This is an example of a spondyloepiphyseal dysplasia in a young girl in her 20s with both the hip joints quite deformed, very arthritic, and the acetabulum is also quite deformed. So this is fairly standard of the type of case that we get in our practice. This is the CT scan which shows the defect in the acetabulum. And this was a bilateral simultaneous cemented total hip replacement on both sides using a femoral head bone graft to reconstruct the acetabulum, and a cemented total hip replacement. Another example of a multiple epiphyseal dysplasia. In this case, the spine wasn't affected that badly. Again, this was a bilateral simultaneous cemented total hip replacement using Asian C stems. We've got good data on Asian C stems now coming up to almost 20 years, which has been presented and published as well. Another example of a high DDH, a Hartofilakidis dislocation, or you can call it a Crow Ranawat grade 4 if you wish, treated with a bone graft. This was a young 17-year-old boy who had had multiple operations for slipped upper femoral epiphysis, and he finally got avascular necrosis. So this was him at 17, treated with a 22.2 to 5 millimeter ceramic head. If the diameter of the acetabulum is small and you can only get in a reamer of 44 or 46 millimeters, then I have no hesitation in using a smaller cup of 38 millimeter or 40 millimeter outer diameter and a 22 millimeter ceramic on polyethylene bearing. And our dislocation rate for 22 millimeter heads is less than 1%. So instability is not really a fear. So these are, again, some of the trauma applications. And you can see this was a femoral head and a femoral neck fracture treated with a cemented total hip replacement. He's coming on to almost 9 years. This was an example of delayed trauma. So this was an acetabulum that I had reconstructed several years ago. And after a few years, he got arthritis of the hip joint. This was treated with a cemented total hip replacement and impaction grafting of the floor of the acetabulum. And this X-ray is follow-up at coming approximately 6 years. This was a case of bilateral ankylosing spondylitis. Again, this was a bilateral simultaneous total hip replacement done using cement. These were AMT stems. These are not classic C stems. So we have both stems on the shelf. This was an example of an arthrodesed hip treated with, again, a cemented hip replacement using a trochanteric osteotomy. We don't really use the trochanteric osteotomy that frequently now, but it is useful to know how to use it. So in difficult cases, if you ever have to use it, then you can, and you can repair it well. This was an acute acetabulum fracture in an elderly gentleman who was in his 60s. And unfortunately, because of a massive pulmonary embolus, he was only referred to me at about 4 weeks. Almost 1/3 of my practice is dealing with pelvic and acetabular trauma. So I do get a lot of cases of sequelae of trauma and post-traumatic problems. So this was the IVC filter that he had in. And when I went in at 4 weeks, the posterior wall was really completely destroyed. And the only way you could salvage this was with a total hip replacement. So this is an acute total hip replacement. Some people like to call it the combined hip operation or the fix and replace. So I've used this femoral head as a structural head graft to rebuild the acetabulum. And then you fix it with a plate which buttresses the graft, because the graft is mainly posterior rather than superior. So it is subjected to a lot of shear stress, and using a posterior column plate really helps in getting the graft compressed nicely. Then you ream and you shape the graft, additional screws to fix the graft, and then a cemented total hip replacement. So you would not believe that you can use cemented THR in an acute traumatic case with bone grafting. You know, people ask about healing of the fracture, healing of the osteotomy. None of that is a concern. This follow-up is at 7 years. And looking at the X-ray, you would not know that it was such a bad bone defect. Again, in impaction grafting, revision hip surgery, we use a lot of impaction grafting on the acetabular side. and also on the femoral side with cement. And then, for some cases we have uncemented, but this is a 5-year follow-up of massive impaction bone grafting. This gentleman had 3 femoral heads that were used for bone grafting that massive defect of the acetabulum. You can see what a big defect that is. So the philosophy we have at Wrightington Hospital is to try and make your revision surgery look like a primary, to try and make the operation more biological, to try and give bone to the patient, and to try and prepare for the next revision that is inevitable. This was an intraoperative complication of an uncemented hip replacement that came from another hospital, probably because of excessive reaming of the floor and then hammering the uncemented cup. And you can see that the entire acetabulum is fractured, displaced fractures involving both columns. So in the first stage, I've taken all the hip out and fixed the acetabulum and bone grafted it and waited for healing. And in the second stage, done a cemented total hip replacement. So this is also a common case that I get in my practice, which is a non-union. So this was almost a 40-year-old non-union, which had been untreated. Multiple operations had been done to try and do something to the acetabulum in the 60s, all of which had unfortunately failed. And he came at about 68 years of age with a very painful non-union with a partial foot drop. And this gentleman had not walked for almost 4 decades. He was in a wheelchair. That was his X-ray. You can see acetabular non-union. And that was the screw that was left in an attempt to give lateral traction. And then the screw broke inside the acetabulum. That was the CT scan. So during surgery, the broken screw was taken out. You can see that the non-union is still mobile. So it had not healed despite 4 decades. Now that is an osteotome that I've put inside to try and mobilize the non-union as best as possible. You freshen the edges, bone graft it, perform impaction grafting, fix the non-union with a plate, and then I've reconstructed this in a single stage with a cemented socket and a cemented stem. So the follow-up. If the X-ray, I do have X-rays of his follow-up. He's coming on to almost 8 years now. This was a revision surgery of a type of a bipolar uncemented stem that was done elsewhere with a lot of pain, and the lateral part of the femur was quite deficient. So again, reconstruction with a longer cemented stem using a strut graft to reconstruct the proximal femur. So we've got good data on strut grafting of the femur, which have been followed up until healing, which I think has just been published in the last 3 or 4 months. This is the case of infection. This was a cemented total hip replacement, which got infected. Unfortunately, multiple DARE procedures had failed, and she had a swelling with a burst sinus with multi-resistant organisms. So my standard at the moment is a 2-stage philosophy for infected total hip replacements. Complete removal of the cement in case of infection, ETO only if required, and in the vast majority of cases, an ETO is not required, and then use of a nail as a spacer. So I ream the femur out, use a femoral nail as a spacer with antibiotic-loaded cement. I prefer non-articulated spacers, and then this was after the second stage, and now she's reaching 4 years. The interesting thing is if you look at the primary hip on the left and the revision hip on the right, you will agree that the revision hip looks more biological, smaller sized, and we have given bone to the pelvis as compared to the primary. And that's the philosophy that I'm talking about. Make your revisions look like a primary, give back bone, try and prepare for the next operation. This was that follow-up. I'm sorry for mixing up the slides, but the non-union case that I just showed, one case before this. So this was the 7-year follow-up X-ray of the healed non-union and a cemented total hip replacement with healed impaction grafting. This gentleman walked for the first time after 40 years. This was a case of pelvic discontinuity with a loose acetabulum. And again, in this case, I've treated it in 2 stages. In the first stage, I like to fix the pelvic discontinuity, bone grafting. And then in the second stage, a total hip replacement. The cerclage wire is prophylactic. When I take out uncemented stems, I prefer not to perform an ETO as far as I can. I just use a prophylactic cerclage and then take it out gently using sharp flexible chisels. This is an example of using an augment with impaction grafting and cement. So you can see that an augment is very good for obtaining coverage and to make your rim complete, and then impaction grafting of the rest of the floor with a cemented socket. On the femoral side, we have used a technique called in-cement revision. So you knock out the old cemented stem, refashion the mantle, and you can use the mantle to put in a new cemented stem with cement in cement. And again, we have good data of over 15 years now of in-cement revision. This makes your femoral revision really biological, and it looks almost like a primary. Another example of a multiply revised hip. So I think this young lady had already had 3 failed hips, and this was the 4th one that I was asked to do. So you can see a big defect in the acetabulum, reconstructed with a combination of impaction grafting and structural grafting, coming to 7 years, and on the femoral side, in cement revision. Another example of an infection in an uncemented stem, and the patient had a malunited femoral fracture below the stem, treated in 2 stages. The first stage is again a nail, reaming of the femur. In this case, I did have to use the ETO because the stem was really well fixed. Non-articulated spacer, and then the second stage, total hip replacement with a cemented stem and antibiotics in the cement. This was an interesting case as well. This young lady came from the middle of Europe. She was riding on a train. You know, like in India, people used to sit on the train, on the top of the train, or on the top of the bus. So this, this kind of phenomenon is common elsewhere as well. Unfortunately, she got electrocuted and had a femoral neck fracture that was treated with a total hip replacement, which got infected. So that got taken out, a spacer was left in, and then she was basically discharged after that. And this is approximately 2 years after her trauma. Extensive burn scars on the side of the hip where you would want to do a total hip replacement. So we had some help from our plastic surgeon if required. Aspiration, all the other tests were negative for infection. And we marked out an incision that was slightly posterior to the burns with the help of our plastic surgeon, so that we did not have to use any flaps or skin grafting. And the reconstruction was with the help of augments, impaction grafting of the floor of the acetabulum, and a cemented total hip replacement. And that's the follow-up at about 5 years. Interestingly, this young lady later on decided to become a doctor and joined medical school. And that's her X-ray at 5 years. She's infection-free and she's pain-free. So those were the cases. And do we have time to discuss evidence, or if
About 2
people
minutes,
are bored, then...
About 2 minutes, Nikhil, then Munjit can start. Dr.
Yeah,
Munjit.
that's fine. So I told you about the survivorship of the C stem at Wrightington Hospital. So we have good data up to 15 years now, with a 99% survivorship for all causes, which effectively you can see is really excellent survivorship. If you get 99% surviving at 15 years, then you can be pretty confident to get 30-year data and 40-year data. Now, I don't know, I showed you one X-ray of a hip at 50 years. This is some of the other evidence from Wrightington Hospital. So when you look at 30-year data, the survivorship is approximately 52%, which means more than half the hips are still surviving at 50 years. And if you separate the indications for osteoarthritis and for DDH, the 30-year survivorship is approximately around 50%. But for low demand patients like rheumatoid or ankylosing spondylitis, the 30-year survivorship is almost 77 to 80%. So the survivorship is affected by the age of the patient and by the indication. If you look at all the data from America, which is very interesting, they don't really have much of 30-year or 40-year data on the different types of uncemented stems. But the longest data that I could find from the United States was, in fact, the Charnley hip from Iowa and from the Mayo Clinic at 25 and at 30 years. So cemented hips do work in the hands of those people who are trained and who do them regularly, and it is a good hip. And this was a systematic review that Dr. Parvizi published in 2013, looking at evidence from everywhere. And basically he showed that cemented sockets are better, and the available evidence did not support the widespread use of uncemented sockets. That was his message. The usual argument that I get is that cement is only good for older people. In fact, just this morning, a good friend of mine from Delhi texted me, how can I ever do a cemented hip in a young patient? So the question I ask is, how do you get 40 and 50-year survivorship data? If cemented total hip replacement was only done in older patients, you would not really get this kind of data because unfortunately most of the patients would be dead by that time. So to get a 50-year survivorship, you have to be doing these hips in 20 and 30-year-olds. This was the 40-year data from Wrightington Hospital. You can see excellent survivorship. And this data is only possible if you do it in younger people. And this patient came for follow-up quite recently, still alive, 40-year follow-up of bilateral total hip replacement. And it's very common for us to see these x-rays in our follow-up clinics. One of the good things at Wrightington Hospital is we have a captive follow-up, and wherever the patient has been operated upon, they get invited periodically to attend the follow-up, and we get x-rays done, and they religiously come to attend follow-up, and that's how we collect our data. Because without long-term data, it is pointless really to describe any technique. And this was a recent presentation on 40 to 50-year data that we had in one of the hip meetings. The registry data also supports cemented hip replacements. In the Australian registry, Munjed is here. He's more of an expert on the Australian data than I am. But to the best of my understanding, they could not show any major advantage of cemented and hybrid between each other, but they were still better than cementless. And that's what the UK registry has sort of summarized as well, that the all cemented hips have the lowest revision rate, but the hybrid hips with the ceramic on poly are also doing extremely well. So I think our modern practice will revolve around a fully cemented hip, but hybrid hips also work extremely well. And probably in modern orthopedics, the weakness is no longer the fixation, because modern uncemented stems, if done properly, also give good data and the fixation is very reliable. I think the long-term survivorship is going to be dependent on wear characteristics. And this is where we hope that the ultra high molecular weight polyethylene, which is highly cross-linked, will come into the picture. And when it is matched with a ceramic bearing, then we ought to get good long-term data in most hips that are performed well. And I think I can finish now, Abhijit.
Yep. Thank you, Nikhil. That was a wonderful presentation with such good data and use of cement in such a variety of hip cases. I mean, those who are doing cemented hips, this really gives a good literature and clinical support to what they are doing, provided it's done right. Now we move on to our next speaker. We have Dr. Munjed Al-Mudaris from Sydney, Australia, who is a clinical professor and high volume hip and knee surgeon. Over to you, Dr. Munjed.
I'll have to stop sharing the screen, isn't it? Or does it happen automatically?
You have to stop sharing. I can do that from here.
Okay, that's great.
Munjed, you're on.
Around the world. My name is Munjed Al-Mudaris. I'm an orthopedic surgeon from Sydney, Australia. And thank you very much, Dr. Joshi, for inviting me to this webinar. I will try to link it now on computer literate. Okay, so I will talk to you about a completely different philosophy, which is completely the opposite of the cementing technique. My philosophy is basically talking about neck-preserving ceramic on ceramic cementless hip replacement, which is the extreme opposite, basically. Have you got the, is it on view now?
No. Dr. Shah, could you help out?
Yeah. Dr. Munjed, are you seeing your PowerPoint?
I can see my PowerPoint, but I'll just...
Just come back to the Zoom panel where you can see our videos.
Yeah.
Just below that, there is below our videos, there is a green share screen button. Share screen tab. Just click on it and you can see your PowerPoint there in that window. Yeah, now it is.
There we go. Yes.
Great.
Yeah, we can see it now, Doctor.
Okay, can you
Yeah,
see it now?
yeah, yeah. We are good. We are good, Dr. Munjal. Please continue.
Okay, so I do a fair bit of hip replacements, and the technique that I use is anterior approach, basically, and this is the only technique that I use for primary hips, and for the vast majority of revision hip replacements. I revise most of my hip replacements um, through the anterior approach, unless it's a periprosthetic fracture and the femoral stem that requires only the femur to be addressed, then I do a posterior approach. So I do have some disclosures, and I am a limb reconstruction surgeon, and I see a lot of patients like the one in the picture with significant deformities. So the way I do the hip replacement is on a standard table. I do not use traction table or any device, so I'm not bound to any company with regards to the choice of implant. And I use different type of implants, whether they are neck preserving implants or standard stems or cemented stems through the anterior approach. I even use standard Exeter stems through the anterior approach. So the objective of this presentation is to review factors that affect outcome of total hip replacement and present anterior approach and my outcomes. If you look at the cross-section of a human body, you can see that the femoral head and the shaft is pretty much closer to the anterior surface of the body. And it does make sense that you would go through the front. And with risk factors, now we're having people in the age of 40s, females, obesity, previous trauma, and different ethnic backgrounds that increase the risk of arthritis of the hip. We see a lot of people from islands like Samoa and Papua New Guinea, etc., and they are big people. So when you try to do a posterior approach hip on them, you have to make a massive incision. And it's very difficult to dig deep inside the body. While with the anterior approach, the iliac, the ilium and the surface is very close to the anterior size. People are living much longer now, so we're getting a lot more arthritis. And if you remember, till 1850, people used to live to 40 years. Now it's expected that people will live to 100 if they survive the coronavirus now. So factors that affect the outcome of a hip replacement, I believe there are three factors: the patient, the surgeon, and the implant. And when it comes to the patient, I feel that the best patient that you can treat is a healthy young female. The second best is a young healthy male, and that's because their body is bigger and stronger, but males usually try to conquer the world and they try to do stupid things. So they are at a higher risk of developing periprosthetic fracture. And the worst patient is the osteoporotic female, where they have a bad platform that you work on, and they are the ones that require due diligence with press fitting, and they have a lot more complications. When it comes to the surgeon, the experience plays the major role in the outcome, and it is all about the experience of the surgeon in dealing with the pathology. And if you look at the Australian Joint Registry, surgeons who perform larger number of surgeries, they have the lower complication rate, as you can see here from the graph. With people that do more than 70 hip replacements, and surprisingly, you can see the number of people that do more than 70 hip replacements per year in Australia are 40. So their complication rate is in the vicinity of 4.6%. The technology is very important. Now you have navigation, etc. And basically, it does help to start your approach. So the commonly used approaches nowadays are the posterior approach, the direct anterior, and the lateral approach. None of them are new. Smith-Peterson invented the anterior approach in 1925, and the Jude brothers used the Jude table in 1947, and this approach had been used in Europe for a very long time. So nothing is new. So what's the ideal approach? I strongly believe that the ideal approach should provide the surgeon with the optimal visualization, should be reproducible by the surgeon, should be less invasive with respect to the surrounding soft tissue without complications, and allow the patient a rapid post-operative recovery, rehabilitation, and return to work. So basically, the best approach is the approach that is done well by the surgeon who know what they're doing. The reason the anterior approach is not done widely because it is believed that it is technically challenging. It's harder visualization due to working between muscles, and you're not cutting any muscles. Some people claim that if you don't use a table, you can't use an anterior approach. I think that's not true. Intraoperative X-ray is required for implant positioning. I use X-ray constantly, and that's just to make sure that my positioning is there, and the way that I position the patient allow us to do proper X-rays. So while the patient is on the table, you can assess your position. Fracture risk does increase in patient with osteoporosis, especially with if the patient is larger in size, and that's in the femoral stem because of the difficulty to access the femur. It is not suitable for patients with significant hip deformities. To be honest, I disagree with that fact because with experience, you can do any kind of hip with utilizing the anterior approach. I do extensile approach where you can extend it superiorly and you can extend it distally down to the knee if you wish. And definitely when I do total femur replacements, I use an anterior approach through that. Surgery can take a long time to perform, and many patients are doing it just well after a year of surgery. But people need to look at that year, the during year that passes, especially that the recovery I've seen from patients who have no muscle cutting to patients who have different approaches. People after 12 days, they can drive a car, they can do pretty much whatever they want with the approach, with the anterior approach if it's done well. So the anterior approach is an approach to the hip from the front. It does not disturb any muscles. It does require minimum trauma to the soft tissue. It is muscle sparing approach, and the incision is much smaller. And the reason is because you don't need bigger incisions, and but it does need a lot of training, and it's not dissimilar to any other approach. I must admit, when I was trained to do a posterior approach on a hip is much easier than doing an anterior approach. However, now I've been in private practice for over 10 years, and if you asked me to do a posterior approach, I wouldn't have a clue how to do it. And definitely I would not be the good person to do that approach. When it comes to implants, implant choice is very important. I agree with Dr. Nikhil. Cemented implants do well and they work. However, my first patient that I did hip replacement in the first year of my practice, I killed a patient on the table due to cementing, and that traumatized me basically. And you get people who are elderly who cannot tolerate the pressurizing of the cement, etc. And it does add another risk that may not be necessarily unavoidable. I believe in restoring the biomechanics of the proximal femur, so metaphyseal loading is very important. So that's why I use in 50% or more of my cases neck preserving implants, and it adds another level of challenge when you use a neck preserving stem. It is very, very technically demanding, because if you don't do it properly, the implant subside, or you get a periprosthetic fracture, etc. So you can get a lot of problems. But you can see there are different type of implants that you can use with hip replacement, and no one is better than the other. They all work in the hands of people that know what they're doing. This is the implant that I prefer, which is a neck preserving implant, and regardless of the company that makes it, it does restore the biomechanics of the proximal femur, and it does have very good survivorship, basically. Now I'm going to talk to you about my results with my first 5 year of looking at nearly 600 hip replacements with minimal 5 years follow-up. And despite using the anterior approach, I've done anterior approach all my life. And I've done the first hip replacement that I did when I came back from my fellowship in Germany. I thought that anterior approach was not commonly available in Sydney, and I was too scared to start it there, not to attract any attention. And I did a posterior approach, the hip dislocated. So I decided, well, I'll better do what I'm familiar with. So I went back to the anterior approach, and I never turned my back. And you can see here, 100% of my patients now are anterior approach, and 100% of the patient that I've done are ceramic on ceramic. And if you look at this figure, this is the revision rates for hip replacement, and you can see my revision rate is 0.4% at 5 year mark. The reason of my revision, if you divide it, and this is an important factor that people don't talk about that often, infection rate is still around 1% with hip replacement. I've done over 1,500 hips, and especially in the joint registry from this series, you can see 5 years follow-up of hip replacements of nearly 600 hips with 5 years follow-up with 0 infection. And that is very, very important. With the anterior approach, if it's done well, the risk of infection is much lower than any other approaches. And that's because you don't lie on the wound, and by not traumatizing the muscles, you will have a lot less injured tissue and inflammation, and a lot less suturing material in and foreign body, etc., that will add complexity and infection. So, however, and I'm not playing the game of arguing that dislocation rate is lower, because this can be arguable. If you do a good posterior approach hip replacement, you will have very low dislocation rate. However, I can tell you very clearly, you can see from this graph that I had only 3 dislocations in my entire series. Dislocation rate is very low. Fractures is common, and you can see the yellow line. It does show that periprosthetic fracture is high. It's the highest complication that I have in my series, but still overall is lower than the rest of the population of other surgeons. So overall, I think we are doing fairly well. Loosening, there is no loosening, or very hardly any loosening, basically. So no infection, no loosening. Leg length discrepancy, you do get leg length discrepancy in small number of patients. When you look at the ceramic on ceramic, for my results compared to other surgeons, again, it is half of the rate of the complication. So it is kind of interesting to see that neck preserving hip, ceramic on ceramic with anterior approach, it does work basically. And looking at the neck type neck neck preserving implants as a joint replacement compared to others, again, it does look like neck preserving stems do work. But as I said, it is very technically demanding. So I'll show you a video of how it's the way I do it basically, and I'll take you through.
So we start the operation by making a skin incision.
I think this is the video. My apology. I'll just mute the video. So I'll just turn the volume down. Okay. Can you still see it?
We can see, Munjat. You're good. Please go ahead.
Okay. So nowadays, this video is like 7 years old. So I do apologize because I used to do it through longitudinal incision. Now I use bikini incision mainly for patients, unless it's a very complicated hip replacement, then I would use a longitudinal insertion, basically. I don't dissect the tissue as I've done back there anymore, because that's really not needed, not required. And I use this self-retainer, which is called an Alexis self-retainer. There is a specialized, back in the days, this self-retainer was used for basically cholecystectomy or abdominal surgery or hysterectomy. There is a standard self-retainer now of this type for joint replacement, and there is a much smaller one that you can use. Basically, you make an incision between the sartorius and the tensor fascia lata. I make the incision over the tensor fascia lata and through the fascia, and just gently dissect the tissue away, separating the two muscles without going through the muscle, and avoiding the nerve, and retracting the lateral femoral cutaneous nerve of the thigh medially in the superior retractor, as you can see. And then when you go through that, you will see the vessels, the ascending branch of the lateral femoral circumflex vessel. You can see here, I'm tying it. I'm just doing this by the book. I stopped tying that 5 years ago. And now I just diathermy these vessels. And you can basically cauterize them, and you have no problems. I put a retractor over the neck of the femur medially, and then you would have two retractors laterally, basically, as you can see here. This is the iliofemoral ligament, and the rectus attachment on that ligament, and you just separate it gently, and you can go underneath it, and you use a number 7 retractor. Basically, the instruments that I use for a hip replacement are only few. I use curved Homans, 3 of them, and I use basically a corkscrew and forceps. It does not require any special instrumentation, and you need only one assistant. And sometimes when you have fellows busy somewhere else, or no fellows, I even use no assistant at all. So you can do it by yourself, basically. I do excise the iliofemoral ligament. I do not do capsular repair, as I come from a school where I believe that the capsule and the iliofemoral ligament is part of the disease and it's scarred up. You can see this labrum is completely ossified, and you can take it off with a chisel. You can see the movement going over the femoral head, over the acetabulum, and you can see the visualization. It's really good. Definitely with the anterior approach, visualization of the cup is and the acetabulum is very, very clear. By taking this labrum off, you can dislocate the hip much easier, basically. In females, you can dislocate the hip by just using the Homan retractors, by inserting them between the head and the acetabulum. In males, it's a bit harder. And you can see with this Homan retractor, I'm just jacking the femoral head out, as you can see there. Because being a male in this case, it is easier to use a corkscrew, and you can see the femoral head comes out. I do dislocate the hip before performing the neck cuts. And I do 2 neck cuts. This is the ligamentum teres, as you can see in front of you. The first neck cut is subcapital to remove the femoral head, and then I perform a proper neck cut based on my preoperative planning with regards to choice of implant. If I'm using a neck preserving implant, I use a mid-cervical cut, and it doesn't affect the positioning or basically the visualization of the acetabulum. If I'm using a cemented stem or a standard cementless stem, I do a cut at 10 millimeters above the lesser trochanter. You can see the visualization of the acetabulum now from that view. And I do agree with Dr. Nikhil, basically, is that the reason of reaming is not to enlarge the acetabulum, but to take the cartilage off. And that's exactly what I do. And I tend to just go to the base and that's it. I don't, I tend to preserve the subchondral bone. It is very important to preserve because that's the hardest bone that you've got. And as long as you reach a bleeding bone, that's all you need. And you can see the acetabulum still have majority of the subchondral bone intact. I use cementless cups. I must admit, I rarely use cemented cups, but there is nothing wrong with that. And I have no regret of using cemented cup if you need to in certain population or in certain cases where you need revision. I use ceramic liners all the time, and I use large heads. The vast majority of my cases, if the cup is more than 52 or 52 or more, I use 36. If the cup less than 52, like a 50 or less, I use 32, basically femoral heads. I do take care in taking the osteophytes from around the cup because they can cause significant amount of impingement. Positioning the cup is extremely important, and you can see when we finish with the acetabular component, there is no basically cutting to any muscle that's or any injury to the muscle. Basically, you just separate them and you go between them. Then the hardest part of doing the anterior approach is basically doing the femoral stem. And it does take some experience to elevate the femoral shaft superiorly. I don't find using a table, despite like working in Australia, you have everything available. Well, used to. I don't know what's going to happen after the coronavirus and if we still have money. As you can see, all countries will be bankrupt now. But I never used a table. I tried a table and I found it a hindrance rather than of help. Now, people ask the question whether the neck preserving stem is easier than a standard stem. Yes, it is, because it's curved stem, but you can use a standard stem like a Korai copy or an Accolade, and that shouldn't be a problem. I even, when I go and do charity work overseas in developing countries, I use as an Exeter stem with its instrument, posterior approach instrument through the anterior approach, and it's a bit harder, but it can be done. You can see I trial with the femoral head and neck, and you reduce the implant, and as long as you have good stability and you maximum external rotation in extension, it shouldn't dislocate. Basically, positioning the cup and positioning the neck is much easier when you do an anterior approach. And you can see that's the acetabulum, the cup, and you can see the cup is just exactly where the teardrop, and I don't medialize it much. but it's sitting exactly where you want it to sit, and the femoral stem is sitting basically as a neck preserving, which is much higher neck cut than you would do with a standard implant. But again, this is a choice of implant, and because I treat a lot of young patients, so I try to use smaller implants and more neck preserving implants, because in the future they might need revision. And if you restore the biomechanics and restore the anatomy, then when it comes to revision, it's you still have bone preserved to deal with. And I do agree with Nikhil that make your revisions as if they are primary, and I strongly believe in that principle. This is a neck preserving stem from Corin. Basically, you can see that's the old brooches that I used. That was 6 or 7 years ago. Because they did have two type of brooches, one for the fin, one for the stem. Now they changed to have a single brooch for both. And I use ceramic femoral heads all the time. So I use hard on hard bearing with ceramic. I have only 2 patients that complained from squeaking, painless squeak, and I strongly believe that the reason of squeaking is because I malpositioned the implant. Local anesthetics is important. I injected thoroughly and with a significant amount. And then when it comes to closure, you can see that this is, I must admit, this is a much bigger incision than what I do now. With experience, like since that video was made, I've done maybe 1,000 hip. So I'm a bit more experienced. I did this video back then in the days when I was trying to, show that anterior approach can be done, and it was, as you can tell, it's a marketing tool basically. The suturing of the fascia is done. You don't suture any muscles, and basically you close the subcutaneous tissue and the skin after that. So basically that's all what you need. I'll see if I can move this a bit faster. Here we go. That's going through the skin and subcutaneous tissue, and eventually the wound is only 5 to 8 centimeters in length. That's it, I think, from my end. Thank you very much.
Thank you, Manjit. That was, Dr. Manjit, that was a lovely presentation. I'm sure there are a lot of questions for you. Shah, should I start my presentation?
Yeah, you can start your presentation.
Should I share a desktop first and then start the presentation?
Yeah, that's how it worked last time.
Can you see it?
Yes.
All right. Those who have questions, kindly please WhatsApp your questions to Dr. Sham on his WhatsApp number. It's there in the messages that we've sent. Okay, so my talk today is on the reverse hybrid THR. Now, we believe that we need to take best of both worlds, the cemented part and the uncemented part. Our approach is we take the advantages of cementing the cup and the advantages of an uncemented femoral compound. Now, both these presenters have presented the advantages of that, and we've taken the best of both of them. And we believe this philosophy is also used to get a good hip replacement results and functions. So as a disclaimer, first, we use a posterior approach all the time. So I won't be going into the details of the posterior approach. I just want to present a little bit of data which will support this reverse hybrid philosophy that we have. At the end of it, I'll tell you about our personal data. So this is a common scenario for us, and we do all our hips with cemented cups and uncemented femoral stems. So indications for a reverse hybrid is basically in the philosophy that all the cemented conditions, all the conditions which require a THR, they can be done with a cement on the acetabular side, and uncemented femoral stem on the femoral side. We do it for acetabular dysplasia and protruso, inflammatory arthropathies, rheumatoids, which are common in India, along with osteopenia. For us, a relatively contraindication is cardiopulmonary disease for the fear of embolization during pressurization. However, there are few papers which said that if you do a thorough cleaning of the femoral canal and of the acetabulum, then the chances are much less. You reduce the chances, you don't prevent them, you significantly reduce the chances. So this is the data from a Swedish paper, and it shows that they do a lot of reverse hybrids from younger than 50 years to older than 70 years. When this paper was published, the cups that they used to use were simple high molecular weight polyethylene cups. The difference starts to stand out when you're using highly cross-linked cups. For the last 7 to 10 years, at our place, we've been starting to use only highly cross-linked cups, and this makes a big difference in the survivability of the cup. So we have a little data on the Norwegian hip registry. Again, this is just on reverse hybrid, and they do it for all. The data is from 2004 to 2018, and they show a fairly good survivability at the end of 14 to 15 years, which is comparable with both fully cemented hips and fully uncemented hips. So in the reverse hybrid, as you can see over here, at the age of 75 years, it's pretty good, almost up to there. And there is a slight difference in survivability, as Dr. Munjit said, when you do a hip in men and you do a hip in osteoporotic female, they somehow tend to have a slightly bad result. And as with the reverse hybrid, as you can see, this graph shows fairly good results at the end of 14 years. This is a graph which shows total hip replacements using reverse hybrid right from 2003 to 2017, and it is showing that under 65-year-old patient, it is a good survivability rate of more than 14 years. This is with primary fixations. And the acetabular cup cementing was done in vast majority of patients who were undergoing fixations in revision scenario. Majority of them used acetabular cups. So knowing how to do a excellent or a very good acetabular cementing is one of the keys in getting a very good long-term result. This another very good paper from the Bone and Joint Journal, which is pretty big. That this is the largest study of hybrid total hip placements, and it shows an excellent survivability for up to 17 years, and it was slightly higher in the male patient as compared to the female patient. Another paper which has a 12-year follow-up. The only reason I'm giving this data is in the Indian scenario, we often are in between whether we want to do a total hip with cement or you want to do a uncemented total hip. It all depends on your philosophy, what you believe in. And in India, the cost factor also comes into play. So with a cemented cup, you save a lot of money for the patient, and at the same time, this is backed up with good philosophy and good data. The Swedish hip registry is also good in getting a data in that. As you can see with reverse hybrid, this is very 2015-17, you have a good survivability. They are using it in reverse hybrid in quite a few number of patients. So it is not that reverse hybrid is not done in other foreign countries. It is being done. As you can see, you can have a good survivability between 16 and 17 years. Total number of reverse was about 3 to 4% in Swedish in 2000 year from starting from year 2000. This has significantly increased in 2017. So with due credit to Dr. Rajan Kothari from Pune, who is the senior orthopedic surgeon with whom I also work, we have about 300 plus still yet to be published data on reverse hybrids. So all our hips are done through the posterior approach. A predominant diagnosis, avascular necrosis of the hip, secondary either to idiopathic or alcohol abuse. We have a mean follow-up of about 15 years. Now in that, about 5% have been lost to follow-up, and we had 2 revisions to a girdle stone because of infection. In our series, we found that by the time we started using highly cross-linked polyethylenes, the survivability of the acetabular cup has definitely increased. The femoral, on the femoral side, in a young patient, somehow they do well. It is there in the data as presented by Dr. Munjat that because of a good bone stock, the femoral stem does hold on very well for a very long time. We don't use, in our cases, we don't use any, I'm sorry, we use drains all the time. And with high molecular, highly cross-linked cases, we are doing much better. Only the local poly is used only in those cases where we are doing charity or low affording cases. Thank you. Now, if there are any questions, please, Dr. Sham, could you?
Yeah, there are quite a few questions.
Yeah, I thought as much. Should I end?
Yeah, end your presentation so we can see all of us.
Yeah.
So first questions to Dr. Shah. There is a question by Dr. Ninad from Nagpur. He's asking, in inflammatory hips with soft bones, sometimes the cement can penetrate the acetabular floor and go inside the pelvis. Any tips to avoid this?
Can you hear me?
Yeah, we can hear you.
Yeah, in fact, if the bone is soft, that is an excellent indication for a cemented hip. You have to be very careful with reaming, particularly if your reamers are sharp. I said that the purpose of the reaming is not to destroy bone, but just to take cartilage out. If your medial floor is really thinned out, then you can remove the cartilage just with that ring-shaped curette that I showed, without even reaming. If you accidentally penetrate the medial floor, that is not a problem at all. For those who have read Charnley's work, he used to intentionally penetrate the floor to judge the depth of the acetabulum, and his original concepts were medialization of the acetabulum to improve the offset. And then he used to put a little metallic Mexican hat into that floor. So if you do penetrate the floor, it's not a problem. Take the femoral head, make some chips out of the femoral head, and then just pack it on the floor like impaction grafting, like I showed for that case with the protrusio, and then you can cement on top of it.
Right. Another question from Dr. Islam Nasser from Gosford. Any cutoff age for neck preserving stem?
That's for Dr. Munjat, right?
This is for Munjat. I think mostly for all panelists.
Yeah, so basically age is, chronological age is not a factor. What's important is that the X-ray finding. So door A is what is required for performing a neck preserving stem. You cannot do neck preserving stem in door C or door B. So it is very important to make sure that the bone quality, so you can get a 40-year-old rheumatoid arthritis patient, and it's not suitable for a neck preserving stem, but at the same time you can get an 80-year-old male with a door A that you can use a neck preserving stem. So the quality of the bone is what matters, not the age.
Right. Another question for Dr. Shah. What are the indications for using long cemented stem?
So long cemented stems we tend to use mainly for revision surgery. So there are 3 or 4 different designs available. In the C stem, there is an intermediate length stem, which is 170, and the long ones are 200 and 240. They come in offsets 2, 4, 6, and 8. For the Exeter, it can go up to 260. So any indication where you would need diaphyseal fixation, you can use a long cemented stem. So it's not a problem of using it for any indication. The difficulty is you have to be familiar with putting cement down the femur and cementing the stem, and there is a learning curve involved to that. So if I'm taking out a 4-hole or a 5-hole failed DHS and converting that to a total hip replacement, then I would probably go for an intermediate length stem, which is a 170 millimeter stem. If I'm doing a periprosthetic fracture where your bone quality is really poor, pencil thin cortex, and you get like a stovepipe appearance of the whole femoral shaft, which is not really very good for a cone conical type of uncemented stem. There are very good indications for uncemented stems. Then I've used uncemented stems where I've used long cemented stems where you would otherwise need a proximal femoral replacement. And the stem has worked extremely well like a PFR combined with a strut graft. And additionally, if that fails, it gives you one more chance to come back and do a PFR 10 years later.
Right. Next question is, in acetabulum, you keep a margin of 7 millimeter between last femur and the final cup. What about on the femoral side? How does it differ? The same thing.
So depending on the implant, we go line to line, like each, like whether you're doing cemented or uncemented. But if it's uncemented, we go line to line. If it's like size 1, size 2, we put it according to that. But that has to be done very carefully, especially in Indian patients where there is a lot of osteoporosis present. So we have to be very careful during our broaching, but it's done line to line.
The next question is, for doing anterior approach without a traction table, what is the exact position of the lower limb?
Yeah, look, you just put the patient flat on the table. If the table has the capacity to break, you make the breakage point at the pubis symphysis, but I break the table only in very muscular and large patients. Majority of the time, you can do the whole procedure without moving the table or the patient at all. And the vast majority, the patient only need to be lying down supine.
Right. Another question for Dr. Shah. In cemented stem for periprosthetic fractures, are you not worried about cement going between the fracture, running the risk of non-union? I think this is a very common question and a lot of people will have this in their mind. Yes, sir.
No, it doesn't happen that way. You can reduce your fracture well, and you can use long cemented stems. If your proximal bone quality is really bad, you can ignore the proximal femur entirely, and you can use a long cemented stem that works almost like a PFR, but you preserve the thin bone of the proximal femur and wrap it around because it gives nice soft tissue support and your abductors are in continuity. So cement doesn't really stop the healing. When you use a diaphyseal stem, the other reason is that healing of the proximal femur becomes mainly a theoretical aspect, really. And that is very similar to using a long uncemented stem. If you have a very comminuted proximal femur, once you get diaphyseal fixation, healing becomes largely irrelevant in an elderly population base. Right. But we use cemented stems even for doing femoral shortening in high DDH. When you bring down the cup and if your hip is very tight and if you have to do a subtrochanteric shortening, we can use a cemented stem. The technique is very well described by the Exeter group, and we have not seen any problems with the cement getting into the osteotomy site or the fracture site. And the third technique is you can use impaction grafting on the internal aspect of the femur and you can cement in that.
Right.
So there's one
Another
question from mine, Dr. Sham, if I can, even I'm getting lots of questions. There's a question for Dr. Munjat, please, if may. One question that has come is, how do you gauge the anteversion of the implant when you're doing an anterior approach?
This is a very good question. The anteversion of the femoral implant is extremely easy because you just need to follow the neck. So the tip of the neck is where the stem, where the medial aspect of the stem alignment is. You don't need to antevert the femoral stem any extra point like you would do with the posterior approach. When you do a posterior approach, you tend to antevert the cup a bit more and antevert the stem to prevent dislocation posteriorly. With the anterior approach, you don't have to do any of that, and you just put it in the natural position that you would, where it follows the natural anatomy.
Dr. Sham? Yeah, Dr. Sham, continue, please. I think he's muted.
No, I'm here. So this is another for Dr. Munjir. Any concern regarding length of stem used in neck preservation surgery, especially neck preservation stems? They are shorter and in varus. So any concern regarding them?
Yeah, look, the neck preserving stems, and I designed my own stem as well, is basically designed on 3-point fixation. So you need to have medial calcar point, you need to have a shoulder at the lateral aspect, and the tip of the stem should be in severe varus where it abuts the lateral cortex, and that should not be loading any weight. So basically it should be just abutting the lateral cortex. So the length of the stem is not as vital as the actual mediolateral diameter of the stem, as well as the anterior posterior diameter of the stem, where it sits in the neck. It's a fit and fill philosophy where the broaching happens as in impaction grafting broaching, where it fills the proximal metaphysis of the stem, of the femur, and the implant fill that space. You would see that it's irrelevant whether the stem reaches the canal or reaches the cortex. It's not an important aspect.
Yeah, there's another question for Dr. Munjir. What precautions do you take when you're doing the anterior approach to save the lateral cutaneous nerve? And do you find meralgia paresthetica in such patients, and how do you manage them?
That is very, very important, because the biggest problem with the anterior approach is paresthesia in the lateral thigh. And you need to pre-warn the patient about it. It does happen in best hands in around 20% of cases. I do have a couple of patients where they had meralgia paresthetica, and that's in the early days where there is a lot of stretching on the tissue. But I must admit, since you become more familiar with the approach, and one trick that I learned with time is that I don't go in the interval between the tensor fasciae lata and the sartorius. I go in the fascia above the tensor fasciae lata and then go underneath it and slide. That way you can protect the nerve. Majority of the paresthesia recover spontaneously, but if you pre-warn the patient about the numbness that they will get afterward, it's a very, very minimal problem to have. Weighing the benefits versus the risks, I still feel that this is a small price that you pay for the benefits from this approach.
Dr. Sham?
Yeah, another question for Dr. Shah. Are there any special brooches for femoral preparation in anterior approach? Special curved brooches?
I think that question is for Dr. Albuderes.
Yeah, right. Sorry.
Yes, sorry. Well, look, I mean, the broaches has to be offset broaches. That's very important, especially if you are starting your learning curve with the anterior approach. Having said that, as I mentioned, when I go to countries where there is no available anterior approach instrument, I use the Exeter posterior approach instruments to do anterior approach. So you can get away with using whatever broaches are there available for you if you are familiar with this technique. But it does definitely help to use offset broaches, offset broach handles, basically, in order to, so you need a lateralized broach handles and anterior broach handles when you do this this anterior approach. It makes life a lot easier.
Yeah, one trick that you could do is when we're learning, we put the Chanley's relocation spoon, as we call it, underneath the hip and elevate it upwards so that we can use the standard brooches that are available for with Indian implants. I've done that, and that is one trick you can do to lift it up. But one has to be a bit careful when you do that. Make sure that the femur, upper end of the femur, is pushed out and the spoon is kept underneath it. Then you can use the normal brooches, and you have to be very careful that you are not going to broach the or break the lateral canal. You have to make sure you have to be in the center of the canal. But we can do it.
Yeah, I do fair bit of this developmental hip dysplasia cases with the CRO 4 and CRO 3 cases, and I do subtroch osteotomies. So the implant of choice in these cases, I'm not good hip cementing surgeon, so I use SROM stem from Johnson & Johnson, and I'm sure you're familiar with the SROM stem.
Yeah.
So they are very straight stems, and they have straight reamers and straight handles. So one trick that I do for that, I deliver the whole femur and neck outside the wound. It does require slightly more time to do releases of the posterior medial capsule. It doesn't compromise the dislocation rate. And as I said, I have only 3 dislocated hips, one of them in completely demented patient. And what I do, the tensor fascial lata insertion on the ilium, I do slight cheating by nicking it a little bit at the insertion, and then I repair that. All you need is just to release 1 centimeter of its origin, superior part, and that will be sufficient to give you much better access to the shaft when I'm doing an SROM hip replacement, which is very straight. And with Johnson & Johnson, they don't have anterior approach instruments.
Right. So next one is from Dr. Sharad. He has asked, if medial calcar and neck breaks during neck preservation, what are the options that we have?
Yeah, that's again a very good question, because that's a problem that if you look at my revision rates, I had 4 revisions for medial calcar breakages, and if you think that it happens in with the learning curve, that's not the case. I had 2 in the last 2 years, basically, and I have reasonably been an experienced surgeon with anterior approach. So they do occur. They do occur with larger patients, and they do occur with patients who are highly active and do not follow the protocols in the early days. I had a patient who entered an altercation literally 2 weeks after the surgery, and he was pushed from a meter height, and he landed and fractured his calcar. So if the implant subsides significantly, then you need to revise it, unfortunately. And the revision is very simple. You can revise it through anterior approach, and you can put 2 cables around the calcar and put a standard stem, whether a Kurai or a cemented stem. But if the implant doesn't subside, you can just protect the patient and then weight bear them gradually. I had a patient recently who had some subsidence of around 1 centimeter, and I chose not to revise the implant actually wrongly because she was not in so much pain, and but then came back at 3 months and she noticed leg length discrepancy because she was shorter. And then we decided to go and revise the implant. But when I went in, I couldn't take the implant out, and that has healed fully and fully integrated. So we just changed the femoral head, and that solved the problem for the patient. In one way, the neck preserving stem is much more forgiving when it comes to periprosthetic fracture than other stems, to some extent, which is completely opposite to what people think.
Right. Another interesting question is for Dr. Shah. Dr. Ninad is asking, how do you convince young patients for cemented THR?
Let me ask Dr. Ninad, how does he convince young patients for uncemented THR? When you don't have 50-year data, when you don't have 40-year data, when you don't have 30-year data. So if Dr. Ninad comes to me and I show him 2 hips and I tell him, this hip has got this much data for 50 years, this hip has got 15 to 20-year data, which one do you want?
Right.
I've never had to convince or unconvince anyone for any particular implant. We just show them the evidence. The National Joint Registry evidence is in public domain. All UK surgeons have got their personal data on the National Joint Registry. And just like Dr. Al-Mudaris showed his personal data, my personal data is in public domain. Anyone can check it. They can check my complications, they can check my results, they can check my PROMS data. I've never had a problem convincing anyone for anything.
Another question is, what are the tips and tricks to avoid limb length discrepancy from both the panelists?
Do you want to go first?
Yeah, I mean, leg length discrepancy is the most common litigation reason in the United States of America. It is of a concern. I must admit, when you do an anterior approach with the patient lying supine, it's very easy to assess it without any other tools. And but still, I always tell the patient that I will tend to lengthen them by a degree within 1 centimeter, and usually people are happy with that. As you correctly mentioned before, the arthritis causes shortening, and people, when they have a hip replacement, they feel longer for the first 6 weeks because they tend to have adducted position, and then when you do the surgery, they are in an abducted position, so they feel much longer, but then that disappears. But I'm in a more advantageous position here when I do anterior approach, because the patient's lying flat, so I don't have to use any tools. Some of my colleagues use navigation for the hip, and I feel that it takes a long time. I don't think it's navigation is needed with anterior approach. That's my opinion.
Yes, so I have a similar philosophy. It's important to counsel the patients beforehand. I actually perform the templating in their presence, and you have to explain to them the difference between true discrepancy and apparent leg length discrepancy. And apparent discrepancy is much more common with an adducted hip, with scoliosis, with a pelvic obliquity, with spinopelvic malalignment. And when they understand that concept, and you tell them that the arthritis has actually shortened your hip, and what you're doing is you're not lengthening it, you're normalizing it by 5 to 6 millimeters. It is very, very common to have a leg lengthening after a hip replacement of less than 1 centimeter. In fact, that is almost the default position. And most patients don't mind. It's when it goes beyond 1.5, 2 centimeters, then it becomes a problem and litigation increases.
For
And then I
Indian
showed you
patients, Nikhil, in your
the measurement technique during surgery that I use to document it. You can use anything. You can use a suture material, a diathermy cord, a chain, whatever technique you're familiar with.
And in Indian patients, I don't think so. They will complain much if you're within a reasonable amount, like you said, 1 to 1.5 centimeters, unless specifically pointed out by over enthusiastic physiotherapists.
So you have to educate your physiotherapists as well.
I mean, that's the very important thing that you need to do. That they just need to do what we tell them.
Correct. And you have to often tell their partners. So if you're doing a hip replacement on a lady and you think that you're going to have to lengthen it, what you have to tell the husband is that you're going to make his wife taller. You're not going to tell the patient that you're going to have a longer leg. The husbands are really very happy with that.
Yeah, I'm sure they are.
So actually, we are coming to close to this webinar. We are already reaching 2 hours. I'll take a last question, which is about the anterior approach. And Dr. Islam is asking about things that can be done through the anterior approach. First, he's asking if ETO can be done through this approach. If an intraoperatively periprosthetic fracture happens or femur shaft fracture happens, can it be extended? Third, can we use a trochanteric hook through the DA approach? And lastly, how do you ascertain the acetabular version through the approach? So,
yeah, I would advise that people, when they start doing anterior approach, they use a longitudinal incision, and that way it's an extensile incision. That incision can be converted to a total femur replacement if you wish. You can extend it to the lateral border of the patella and up to the on the iliac crest and go to the PSIS. It's very extensile incision. So definitely the answer to that question, you can use extended trochanteric osteotomy, and you can use cables, and I've done that several times. As I said, calcar fracture and intraoperative fracture does occur on occasions, and I had intraoperative fractures. One was just recently. As I said, I had 2 cases in the last 2 years where I fractured the femur, despite thinking that I'm fairly experienced. With regards to a hook plate on the GT, it is hard to do without extending the incision, but it can be done. But cabling alone is very easy, very simple. But trying to put a hook plate, it's not easy to do through the anterior approach, because the hook plate sits at the back, and it's very difficult to do. So if you have a DHS, for example, to remove it, you can do that through small nicks in the skin and then pull it out. But inserting a plate, it's not that easy at the back. With regards to the acetabular version is extremely easy with the anterior approach because the patient is lying supine. There is no worry about pelvic tilt. There is no worry about the lumbar lordosis. And when they're lying flat, Australia is very famous about the 360 and the OPS system and all of that technology. To be honest, I think it's rubbish because it does not reflect the pelvic obliquity when the patient is under dynamic conditions. So when the patient is lying flat, you position your reamer and your acetabular like brooch handle exactly 20 degrees and 45 or 40 degrees of inclination and 20 degrees of inversion, very easy in relation to the line of the table, basically.
Right.
All right. I think we have reached the end of our time, and I would like to thank Dr. Nikhil Shah and Dr. Munjir for taking time off and giving their views on cemented and uncemented implants. And I hope the audience has benefited with that. And I also like to thank Dr. Sham for being such a great webmaster and arranging all this stuff. And thank you very much, Sham. And if there are any further questions, you could email the participants directly. Thank you.
Sure. So
Thank you very much.
we had around 1100 people joining us for this webinar, and there were quite a few questions still unanswered, but maybe next time.
Next time.
Thank you very much.
Thank you.
Bye.
Bye.